Hello, and welcome back to the VJHemOnc podcast. Today's episode focuses on accelerated and blast phase myeloproliferative neoplasms, or MPN-AP. Patients with MPNs in the chronic phase may undergo leukemic transformation to blast phase MPN, which is often preceded by the accelerated phase. Stay tuned to hear leading experts discuss the diagnosis and management of this challenging entity. This podcast is part of the MPN channel on VJHemOnc, which is supported by Therapeutics. This supporter has no influence over the production of the content. This podcast is intended for healthcare professionals only. To begin, you will hear an interview with Anand Patel from the MPN Workshop of the Carolinas 2025. Dr. Patel discusses the diagnosis, risk stratification, and management of patients with MPN-AP. Dr. Patel, how do you identify patients with accelerated or blast phase MPNs?
So really, the things that we look at when we're thinking strictly about the definition is blast percentage. So 10 to 19% blast, whether it be in the blood or in the bone marrow, is associated with accelerated phase disease, and greater than or equal to 20% blast is associated with blast phase disease. I do think it's important to note that the clinical history, once patients have greater than 10% blast, is fairly similar, no matter kind of what their absolute blast percentage is. So really, in my mind, I really like to think of once someone has more than 10% blast, they're behaving like they're in evolution to acute leukemia, even if they haven't yet hit that threshold of 20%. Now, when patients have this progression, oftentimes there will be acquisition of high-risk mutations. So we do also reprofile patients molecularly, look for things like TP53, ASXL1, RUNX1, and IDH mutations. So sometimes those molecular features can also be clues into the fact that a patient is starting to have progression from their chronic phase MPN to the accelerated or blast phase of disease.
And is there an approach to risk stratifying patients with accelerated or blast phase disease?
A great question. I think the first point I want to highlight is, unfortunately, even when you risk stratify patients, outcomes are still fairly poor in this patient population. So a median overall survival of less than 1 year. That being said, we've done some work to identify, can we use AML-based risk stratification criteria to identify the particularly high-risk subsets of patients. And when we use, for example, the ELN24 AML lower intensity criteria, we do get reasonable stratification. We identify patients that are particularly high risk, such as those with TP53 mutations. Ultimately, though, I'd say those risk stratification tools are only moderately informative. So to put things in perspective, you can apply something called a C statistic to the application of risk scores. 0.5 is like a coin flip, 1 is perfect, and the AML-based risk criteria operate somewhere in the neighborhood of 0.5 to 0.6 in terms of how effective they are. So better than a coin flip, but not by a whole lot.
What are the treatment options being explored in this patient population, and which approaches are particularly promising?
There's been a lot of treatment changes in acute myeloid leukemia, and many of those are what we then utilize for patients with APBP. Unfortunately, we haven't really moved the needle very much in terms of outcomes. So historical outcomes for accelerated blast phase MPNs are somewhere in the neighborhood of 3 to 6 months median overall survival. When we looked at a modern cohort of patients, so 2017 to modern day with these newer AML therapies, median overall survival is still only about 10 months. So while we kind of leverage therapies available to us from the AML population, those therapies aren't really moving the needle in the way that we'd like for accelerated blast phase disease. So I think there's been a lot of preclinical work done identifying potential therapeutic classes of drugs, such as BET inhibition. We've done some retrospective work looking at IDH inhibition that we're now looking at prospectively. The target that I'm most excited about is LSD1. So there's quite a bit of clinical data on the role of LSD1 inhibition in chronic phase MPNs with the LSD1 inhibitor bomedemstat. We are leading a study in collaboration with the NCI CTEP program looking at the LSD1 inhibitor iadademstat. So hypomethylating agent plus or minus iadademstat. This combination has shown great benefit in AML, and now we're looking to see if it translates into accelerated and blast phase MPNs. And we also want to do this in a randomized fashion to really elucidate, is there a benefit beyond the HMA part of therapy? And this will be the first study that's actually looking at therapeutic intervention in a randomized fashion for accelerated blast phase disease. So I think it's really important for us to kind of move into that era of really thinking about therapies in a rigorous way and comparing them to the standard in a rigorous way.
Next, can you provide some insight into the role and timing of allogeneic transplant in MPN-AP?
We know that allo transplant is really the only curative modality for patients with accelerated blast phase disease. We also know that some degree of disease control is essential for patients to have durable outcomes post-transplant. In the accelerated phase, there are data to support taking patients directly to transplant without blast reduction. So a study led by our European colleagues looked at these patients specifically and found a 3-year overall survival of about 65% for patients in accelerated phase that go directly to transplant without blast reduction. Now, in blast phase, greater than or equal to 20% blasts, in general, our paradigm is to try and reduce the blast percentage at least down below 10% and perhaps even down below 5%. The major issue is when we look at the outcomes of patients post-transplant, it does not seem that blast reduction is a great proxy for who has cure with transplant and who relapses post-transplant. So in my mind, when thinking about transplant eligibility, of course, age, fitness, other medical comorbidities, just thinking about, is someone an appropriate candidate for transplant in general? And then when thinking about disease-specific factors, in my mind, the big thing is trying to have the disease more approximate a chronic phase of disease. So ideally trying to get that blast percentage down below 10%. We don't know if trying to really strive for less than 5% is all that beneficial. We do know that if we're taking patients to transplant with 20, 25, 30% blast, it's very, very likely that they're going to have an early relapse post-transplant.
And finally, what advice would you give to physicians managing patients with MPN-AP?
The biggest thing I want to stress here is that there is no standard therapy right now for patients with accelerated blast phase. There are several therapies we can try, but none of them are very effective. So this is really a population where the best option for them is oftentimes a clinical trial because our standard therapies are ineffective. With that in mind, I think it's also very important to clinically profile patients, not just in terms of peripheral blood counts, performing a bone marrow biopsy, but also making sure you're doing molecular testing. About 25% of these patients will have an IDH1 or IDH2 mutation. So we do have targeted therapies that are available. Our role of targeted therapies in myeloid malignancies is expanding. Some of these patients may have other targetable aberrations like FLT3, NPM1, or KMT2A rearrangements, where we can leverage other FDA-approved targeted therapies. Early referral to a center that has expertise in accelerated blast phase disease is important, particularly thinking about if the disease is well controlled, a patient will need to ultimately receive a transplant if they're eligible for it. So the earlier on we can be involved in that process, I think that is the best route to hopefully have a durable long-term cure for a patient.
For the second part of this episode, you will hear a roundtable discussion from the 3rd International Workshop on Myelodysplastic Syndromes and Myeloproliferative Neoplasms, in which Adam Mead, Charlotte Brierley, and Juan Carlos Hernández-Boluda outline the challenges of managing accelerated and blast phase MPNs and highlight the need for biomarkers to identify patients at risk of progression to aggressive disease. The experts also comment on the role and timing of transplantation for patients with myelofibrosis and conclude by discussing the impact of TP53 mutations.
Hello everyone, my name is Adam Mead. I'm a haematologist based at the University of Oxford, and we're here in Lisbon at the MPN meeting, where we've just had a terrific session focused on accelerated blast phase MPN and transplant in myelofibrosis. And I'm joined by my panel members who I'll hand over to introduce themselves. Charlotte.
I'm Charlotte Brierley. I'm a clinical lecturer at the University of Oxford.
And I'm Juan Carlos Hernández-Boluda, and I'm a hematologist working in Hospital Clinic of Valencia, Spain.
So in this panel discussion, we had a number of presentations really focused around accelerated blast phase and some of the challenges of managing those patients in when they progress from chronic phase of MPN to accelerated blast phase. Dr. Brierley discussed her recent paper in Nature Genetics, which maybe you could tell us a little bit more about.
I think the paper mainly just shows the power of really profiling the disease biology in these cases and demonstrating that how much we can learn from molecular biology and how important it is to integrate molecular phenotyping into our clinical trials design, in particular in these patients who have a really poor outcome at the moment and represent a big unmet clinical need. So I spoke on, and you can look up the paper for the full detail, but I spoke about the fact that, deploying state-of-the-art molecular biology techniques has allowed us to identify a rearrangement on chromosome 21 that wasn't hitherto appreciated, and it appears to be that this is a genetic driver of the disease, and it might indeed be targetable if we can come up with the right clinical trial setting to test it in.
One of the kind of repeated issues that came up for discussion is whether we might find better ways or biomarkers to identify the patients who are on a trajectory towards a very aggressive disease, so that we might intervene a little bit earlier. I mean, obviously there's a lot of activity and attempts to do this. Do you want to summarize where we are now and how we might go about trying to improve those approaches?
Yeah, so I think we have, from the risk stratification systems that we have an appreciation of who the bad players are. And often in clinic, I think we will know who the patients are that we're worried about. But it's still difficult to know exactly at what point to intervene. And as you were saying, the timing of when to transplant is a really thorny subject. Mm. And I think there's still lots to be done about understanding how that latency of the disease is impacted by the molecular biology, and really understanding what the drivers and also restraining forces in some of these cases on the clones, because there are some that don't progress.
Yeah, Adam, I think we have a consensus that the limitation of the treatment that we have now in the accelerated and blast phase, and actually, as you said, the need to intervene before, maybe due to biomarkers and so, but I think we have some consensus that the blast cell count in peripheral blood we can actually act before the patient actually fulfills the criteria, WHO criteria of accelerated phase. With more than 4% of blast in peripheral blood, probably could be a target for intervening with some disease modifying or trying to change what we are doing currently in clinical practice, maybe in clinical trial, or just with the tools that we have, like interferon, trying to decrease the clone and so on. I think there was a kind of consensus that something should move in that direction.
Right. Yeah, absolutely. And you gave a nice presentation on transplant for myelofibrosis, and there was some good discussion about the timing of transplant. And this definitely comes up a lot, right? That patients maybe are scared by the risks and decide to go with a JAK inhibitor, and then they slightly disappear from the transplant center, and then they come back when things are very advanced. Yeah. So do you want to kind of give us your reflections about that and how we might think about improving this?
Exactly. Well, I mean, I think we currently have very good prognostic tools to identify patients that have what we call high-risk myelofibrosis, which is an expected survival of less than 5 years. But this is very broad. So many patients, when you explain what a transplant and the risk of transplant, they don't want to actually be submitted to such a risky procedure upfront, and they want all these medications that we have currently. So it's fair enough, but the problem is that you have to use this tool when the patient have good clinical condition, have an spleen response and so on. So the monitoring is very important. So you can start medical treatment, no problem to my point of view, but then there has to be kind of controlled by some myelofibrosis specialists and so on. It cannot be just be in a small center with the lots of disease entities that these physicians are taking care of, and they don't actually are active enough or proactive enough when the disease is transforming. So I mentioned this in my talk because I think that in clinical practice is one of the main issues in this. Not so much if the patient has to be taken upfront, but not too late because of that, inadequate monitoring.
Yeah, just you need the timing just spot on. Yeah.
Yeah.
So one of the kind of repeated subgroups of patients that came up, and I presented a case history with patients with P53 mutation. So maybe both of you can comment on this. Maybe, Charlotte, first you could comment on why you think these P53 mutant patients have such an aggressive, kind of terrible disease trajectory. And then maybe a comment afterwards about transplant in these patients with P53 mutation, if and when you should do that.
So I'll start by saying that there has been an increase, a new insight into the biology of this disease in just the last couple of years. I mean, the allelic status of TP53 is very important, and that should be something that we should be looking at routinely when a TP53 mutation is detected. So the thing is that they clearly behave differently in terms of the impact on the genome of these patients, and they often develop widespread aneuploidies and chromosomal instability, and that clearly is a sign that a patient is going down a bad trajectory and transforming into a much more aggressive disease. And I think it's that process of generating aneuploidy that somehow seems to dysregulate the cell in such a way that really our current treatments just do not in any way suppress that clone. But I think there are some signals in the biology that there might be other treatment targets that we might be able to think about in future. And I guess the other point is that clearly these TP53 mutant clones also in other myeloid disease contexts are exerting an impact on the microenvironment that becomes very immunosuppressive, and how we target these interactions between mutation, inflammation, immunosuppression, that's all not worked out yet. But there is some hope that as the disease biology is better understood, that we might be able to target that as well.
Right.
For now, transplant is our only option, but as we saw, it's not a good option.
Yeah, but I mean, going to what you have said, which I totally agree, is the allele burden is very important, because you have many patients with ET and PV that they have a very small clone of TP53 and they are stable for many years. So it's puzzling how these patients are just behaving like this. Now, if we did identify these patients, we probably would select interferon in place of, for instance, hydroxyurea to these patients. But even with hydroxyurea, they have stayed there. We have looked at that retrospectively for many years. So the allele burden, I think, is very important. Once they are in myelofibrosis, for instance, in our database, again, 10% of allele burden discriminates to different prognostic groups. But I would suggest that even lower allele burden should be considered as an adverse prognostic factor in myelofibrosis, because now you have more heterogeneous or complex molecular abnormalities in this disease. And we don't have good treatments for this, is for sure. Even transplantation, the results of transplantation, particularly if there is multi-hit TP53 mutation, and they are very, very, very bad prognosis, but it's the only potential tool to have long-term survivals with this type of mutation, multi-hit TP53 mutations.
One of the things that I think is interesting about the multi-hit, and they are very bad ones, but those multi-hit patients must at some point in time have been a single hit, right?
Yeah.
And they must have been a small clone before they were a big clone. So the question for me is, if you can identify these small clone patients, but identify which ones are on that trajectory towards multi-hit status and which ones are just going to stay stable. One of the things we're trying to do in our lab is tackle that with single cell genomics analyses to really pick out whether, even when there's a low allelic burden P53 mutation, is it a multi-hit clone already at a very early stage? And maybe if you took those patients to transplant early because you knew they were on that bad trajectory, possibly you might see better outcomes.
Another thing is that in our current recommendations, we say, for instance, NGS only for patients considered candidate for transplant with myelofibrosis. Probably now is the time that we should use NGS also in ET and PV at diagnosis, at least in the younger patients, to identify these small clones and try to, because now the recommendations is only this selected population of myelofibrosis candidate for transplant. But I think this is the time probably to move forward and do that in the earlier stages of these diseases.
Terrific. Well, lots more work to be done. It was a terrific session. Thanks very much for taking part, and thanks everyone for listening.
That's all we have for you today. Thank you for tuning into this episode. Don't forget to follow us on X at VJHemOnc to stay in the loop, and subscribe to our podcast on Spotify, Apple or Podbean so you never miss an episode. Until next time.